Welcome to Prostate Cancer Uncensored, a podcast produced by Zero, the End of Prostate Cancer. My name is Dr. Reggie Tucker Seeley, and I am the Vice President of Health Equity here at Zero, the End of Prostate Cancer. As part of our Black Men's Prostate Cancer Initiative, we have had several conversations in our podcast series. One with the leaders of the Black Men's Support Group, and one with an advocate, Mr. Grant Hill. It is my pleasure to introduce our next conversation. A member of our Health Equity Task Force, Dr. Joseph Osborne, a radiologist who is the Chief of Molecular Imaging and Therapeutics and a professor of radiology at Weill Cornell Medical School, recently had a conversation with one of his patients, Mr. Faulk, an African-American prostate cancer patient, about a recently FDA-approved radiopharmaceutical medication used for the treatment of metastatic castration-resistant prostate cancer. Dr. Osborne, Ms. Kyla Dixon, a radiopharmaceutical research technician in the Department of Radiology at Weill Cornell, and Mr. Faulk discussed this new treatment. They also discussed the eligibility criteria and Mr. Faulk's experience with this new treatment at Weill Cornell, including side effects. We at Zero are committed to uncovering the pathway to healthcare equity for prostate cancer patients and survivors and their families. And fortunately, Mr. Faulk had a very positive experience in the healthcare delivery system with positive results. It is our pleasure to share this conversation with the Zero community.
So, hi, Mr. Faulk, how are you?
Hi, how are you today, Kyla?
I'm well. Welcome to our Prostate Cancer Uncensored podcast that's produced by Zero, the End of Prostate Cancer. I'm Kyla Nixon, and I'm here with Dr. Osborne.
Doctor, pleasure as always. Yes, yours and mine.
And we're here today to talk about the new innovative treatment, lutetium PSMA treatment of metastatic castration-resistant prostate cancer. And we're so happy to have you here. Thank you for joining us.
Thank you for having me.
All right, Dr. Osborne, just go ahead and introduce yourself. Tell us a little about yourself.
Okay, well, I am Joe Osborne, and I'm the Chief of Molecular Imaging and Therapeutics. And it was my absolute pleasure to start doing the lutetium PSMA therapies this year when it was approved by the FDA. And my intent in doing so was, of course, to treat all patients with prostate cancer who need this therapy. But also I had a special interest, which was looking at African-American men, men like me and my father, who have a disproportionate burden of prostate cancer. But also we see other pockets of need. Veterans, people who potentially are in low socioeconomic status neighborhoods, people who are older than 65. And so it really was broadly a question of access. So I wanted to make sure if we had the best available treatment, we also are able to give it to everybody, because that's what, as a physician, I should do.
All right. And for you, Mr. Faulk, how was your prostate cancer journey? When were you diagnosed and how did you end up at Weill Cornell?
Oh, it's a long way. I was diagnosed approximately 14 years ago, going on 15 years ago. And at the time, one of my friends had prostate cancer, and he suggested I get tested, and I let it go. I didn't do it until there was a problem. I had some very tight pains in my back that caused me to go to the doctor. And we found out from tests at that time that I was had prostate cancer. And at 6, they start to treat. If your PSA is 6, they start to treat for cancer. And mine was at the time 650. In a week, it went to 1350. It was very fast moving, aggressive, and just taking over. They gave me 3 months to most 3 years to live. And as I say, that's 14 years ago now, 15, because of good doctors like Dr. Osborne, my oncologist, my urologist, and my practitioner, pilot practitioner. We were able to come to various treatments that were minimal compared to maybe my condition, perhaps of my age. I'm 77 now, so you do the math. And that's one of the reasons they go is rare, inoperable. When I say rare, half of the prostate the prostate is in two halves actually. So only one half had the cancer, the other half did not. And like I said, they said it was rare and inoperable. So we went for treatments and to try to keep them at a minimum. I don't want a strong chemo that would cause you, I don't care about the hair because it loses it anyway. But the physical effects of it and degrading, just loss of weight, loss of motivation, these things like that also is a part of the treatment from some of these chemos. So it was not that aggressive, but it was successful. But I've had several, I had made notes and had the names, but I'll forego that at this time. But I went through each treatment. They have a longevity, and it's limited. Once it has helped you, it gets to a point where it's no longer, the side effects are greater than the benefit. So I had about 3 or 4 different types, and they had all run the gamut. And here I was without treatment, maybe 6 months or half a year. This is going back last year. And my oncologist, Dr. Dosick, suggested that I see an oncologist here, Dr. Nannis, who introduced me to Dr. Osborne. I was thankful for that. And introduced, finally, once it was accepted here for use in this country, because I think it came from out of Italy, we began with the treatments of, I call Pluvicto. You call it the right name. And when I started to take the Pluvicto, I was basically bedridden because I had no treatment for 6 months, and it was wearing on me. And it was hard to even get up. I brought myself to pull myself up, so, to get up, sit up in bed. Okay, but 1.5 days after the first treatment with Pluvicto, I was up out of bed, making breakfast, moving around. It was an immediate response physically. For me, it was a revelation. It was God only could have provided me with something that could do this for me. And needless to say, I was very pleased for that. And this continued. Oh, okay. The first day, I said day and a half. So during that first day, I was nauseous. I did, to some extent, small, but did. And after that, nothing. No side effects that I was able to notice, except that I learned over time that mucus, it can build up mucus inside of you, and it lowers your white blood cells. And other than that, but I haven't felt it physically. Physically, I felt very strong. Since the first, this is now today, I'm going to have my 5th. There are 6 treatments, 6 weeks apart, and this is my 5th treatment today. And I'm so very thankful.
Well, that's good news. Speaking of the Pluvicto, how was it decided that was the best treatment for you?
Well, I think wise men like Dr. Nannis and Dr. Osborne came to the conclusion that having seen the various types of treatments that I had gone through, there was nothing left. There was nothing left, basically, as an alternative here, as I say. This came from Europe, I understand, and it had to go through the rigors of being okayed, or what do you say? The medical
Approved.
Approved, yes, that's the word I'm looking for. And so once it was approved, they said, hey, let's try this, see where it's at. I think there was one other patient you were treating with it at the time, but she only had a couple of treatments. And so it was very new, and I was very excited. And I've been so thankful to Dr. Osborne and Dr. Nannis and Dr. Dosick for coming to this conclusion. And this type of treatment so far has continued to be very helpful.
I'm glad to hear that. And Dr. Osborne, is this treatment now available to everyone?
This treatment is available to everyone who fits the eligibility criteria, right? And it's becoming more available as more doses are able to be synthesized, basically, from. But I have to include one really important person, and that's Mary, right?
Okay.
Because you were
my wife, yes.
You were our second patient starting back in May. And by the time you came in, we were already on first name basis with Mary, right? So because she had called many times on your behalf, because it requires sort of chains of trust among the physicians. And I know with Dr. Nannis, he is looking and trying to find people who he can help. And also, in the first iteration of this treatment, it is the caregivers, it's the relatives, it's the family, it's the community that comes together and says, this is going to work, this is going to be good, this is somewhere you can go. And I have to say, as a provider, from our people who have been scheduling, like, Sheila Robinson, who's one of our schedulers.
Sheila's just
right.
Yes, indeed.
Sheila always comes to me and before, even a week before you come, and she says, Mary called and this is what we're going to do. And so everybody is very engaged in the process of making that happen.
And lady was here at that time also.
Right. Lady was here. And between Lady and Sheila, there have been so many tears of joy, even when you haven't been here.
Yes.
Because things worked out very well. So I definitely, with Sheila and Lady and Mary, want to say it's community that has actually made this happen. And everybody should have that same community.
Yes. And
then everybody will get it. So part of the eligibility is that, the doses are available, but we have to find a way to make sure everybody knows that they're available and how to get to them. And for us as physicians, how to get to people. Because it shouldn't be on people to weed through hundreds of pages and internet links to find us. We have to be out there, right?
And I'm hoping this podcast will help do that.
That is exactly what my hope is, that people see that these are things that are possible, right? Because there's been some great days, and before that, there were some dark days.
That's true.
Right? And the way to potentially get out of the dark days is to look and connect with us, I hope.
And what would make someone a candidate for the Pluvicto treatment?
So for the eligibility right now, it's mostly having a number of other different therapies eventually fail. As you said, even when they work, they usually work for a while, and then the efficacy versus side effects, things change, and then another therapy is the next thing to do. When I started doing this about 14, 15 years ago, there was basically one thing, right? And if it didn't work, it was tough. Now there are 6 or 7 or 8 things. So it's up to the Nannises and the Tagawas and the Dosics to say, here are 8 options, and this is how we're going to do this first, this second, this third. Pluvicto right now is usually one of the last things.
Right.
But, because of the side effect profile, which is really not much, if it does help people, it is, really quite something.
Quite something. Without a doubt. The side effects are some mucus build up. You may hear me coughing. I'm sorry about that. But, and it lowers the white blood cells. And this is something that needs to be maintained. And the doctors here are in an effort to do that. And some treatments I've had, full treatments, and I've had partial or lesser amounts of the treatment, depending on my white blood cells by my blood test, which I give the blood, and they analyze it before I'm okay to take the treatment. So it's being monitored very closely. But those, the lower of the white cells, the mucus, this is minimal compared to my ability to get up and move around and be a productive part of my home life, which is like a family life, because it takes a network. And I must say that the bedside manner here at Weill Cornell has been exceptional. And it helps towards the healing process, not just the Pluvicto or any treatment. It's the people that administer and talk with you and treat you. And that's been unbelievable, just like the Pluvicto has been for me. And I appreciate it.
Well, thank you. We definitely appreciate you and your family. And I have to say, when you came in the second time and you did a little dance routine with Lady, it's like it was like crying everywhere, right?
I remember that,
right?
Yes.
So it's mutual.
I had to show off a little bit.
Did you come across any barriers when you were trying to get your treatment, either here or at your other location that you were at previously?
No barriers. Only the waiting till they were able to get it here. It wasn't even here, and then the approval. But Barry, no, all the doors were open. They were like, John, go ahead and get this. Yeah. Because we believe this is new, but it doesn't mean eyes weren't on it for a long period of time, medical eyes. And they had a very good, obviously, feeling about its ability to do what it has done for me. And in this case, my case at least, it's been absolutely correct and on time. Maybe I'm more suited. I don't know. Every individual is different. I don't know exactly, but for me, it's been a revelation, as I mentioned.
And Dr. Osborne, in what ways are you and your team working to navigate those barriers that Mr. Faulk just mentioned?
Well, the first thing is to acknowledge that physicians and hospitals are a part of it. They're a part of the actual barriers. It's not just, patients are reluctant. When you say you can help someone and people aren't actually all that reluctant to be helped. Mm-hmm. So physicians will frequently say that it's this reluctance. It's not, right? It is up to us to learn about the product, to figure out how to do it, and how to push systems, how to push hospitals, right? I mean, the people who are employed here are terrific, but it doesn't mean we don't have to push the hospital system to do better, right? It does, it means that we have to be out there in support groups and survivor groups and places like Zero, putting the word out, right? Because if we're not doing that, then it's not something that people necessarily know about. I mean, it was just approved. And so there are many places where things weren't started early, where they're still waiting to do the first patient, right? For us, we had done research for some time, starting with Neil Bander and Scott Tagawa on PSMA. So we were very familiar with what it potentially could do. So we definitely were an early adopter. But everybody should be on this bandwagon, as far as I'm concerned, who has the ability to do it safely. Because safe is everything, right? You have to make sure you're doing positive things. We do no harm. So if it can't be done safely, then it shouldn't be done. Right.
That's one of the reasons that I appreciate the scanning after treatment. It's very key. And I see the care and following up and seeing how is the body reacting to this today, this time, and each time. It's very helpful.
Yes, and I have to say my colleagues in medical oncology, Dr. Dennis and Dr. Nassif, I mean, they're part of the safety, right?
Mm-hmm. Yes.
And so they're seeing you, making sure your white cell counts are what they should be, and your general health. And for physicians also, one physician does not do it.
Right.
It's actually a team, and you have to trust the rest of your physician team to do the right thing. And that way we can sort of move along and get everything done.
And here it's been rather smooth, I must say. I appreciate
that. So the side effects you mentioned, you said just the cough and the white blood cell count. Dr. Osborne, are there any other side effects that patients should be aware of before they enroll in this type of treatment?
Well, sometimes patients, well, many times, because it's a treatment for advanced prostate cancer, people come into the treatment with other treatment-related problems. And so sometimes they have a difficulty with their urinary system. And so we have to be very clear and understand what their kidney function is and whether they can take the treatment or their platelets or their white cells. So it's very important for us to look at how someone comes into the treatment, because sometimes it's those things we just don't want to push it any further, right? I think if people came in without that, we would see very few side effects. But everybody is an individual here. We have to listen very carefully to what someone is saying, because there's no pattern like there is with other types of treatments.
Okay. And your process for navigating the prostate cancer treatment, was it made even more difficult with the COVID-19 pandemic?
Oh, yes. I don't know about the pandemic. I mean, it seems that the pandemic, I don't know if it's still existing now or it's not, but I came into this after it supposedly had subsided pandemic-wise. But I was tested positive about 3 or 4 weeks ago. And I had no symptoms, very symptomatic. So whatever Pluvicto is either, it's definitely not a drawback to having been tested positive, but perhaps this helped because I was symptomatic and felt nothing whatsoever different. It lasted for a short period of time. I now tested yesterday and it's negative. And I came through it unscathed. And I don't know if because of Pluvicto or certainly not. It didn't have anything to do with getting or coming down with it, certainly because of the lack of severity of the symptoms and my experience of it. My daughter was positive a year or two ago and we almost lost her. So it's very different for me. Whatever my blood is strong enough to withstand COVID-19 with Pluvicto, as far as I'm concerned.
Well, we were very concerned for you in between the doses when we heard about it.
Okay.
But it seems like whatever is thrown at you, throw right back. Like a fabulous attitude, and it's
God is good.
Right. It's random how some of these things happen, but we're grateful that the good side of sometimes random events seems to happen to you, and we're thrilled to have you.
Yes, and I hope that you use some of this information as your study on this treatment and with your patients, and because it can be helpful in that way. Well, this is what this one experienced. Well, we don't know what this one is, but this is this, and make a record of it. It would be very good.
We definitely do. We always look at all of the information, and for me personally, when I joined the Moderna phase 3 trial, the reason I joined the trial is because they needed to know and include African American males. This time, African American males with mild hypertension, because that's what. So people knew with the vaccine that this is a group that was included. It's very important to be a part of it, because you can't, without being a part of something, things can't be measured.
That happens to be the shot I had was Moderna.
So a very popular topic right now in medicine amongst cancer researchers and providers is health equity. And just wanted to ask you or get some insight on your experience. Do you feel as though your navigation throughout the medical system with prostate cancer was equitable?
Oh, I feel without a doubt, I feel it's equitable. I have been treated with nothing but kindness, professional manner, and caring, and I feel that through this whole process, those who I put my health in the hands of have been very forthcoming, have been very honest, and I mean, to a fault maybe, but I like to hear it like it is. And again, I have to speak about bedside manner. I mean, everyone that I have experienced here and my oncologist and my urologist, personal care doctor, it's been, the door is open and they're looking to interact with other physicians in the field and to make things happen for a positive end. I think that they don't have on their mind, I got this ego, I have to heal this person because that's what I do, I'm good at that. I don't get that. I get that their mind is open to the research behind what they're doing and opening the doors to accept other researchers and what their results have been and what do they think. So it's like a concerted effort on a mental, intellectual, scientific level to determine what should happen with this patient and how it should be. So I feel it's very equitable as far as I'm concerned. No complaints whatsoever.
That's great. Dr. Osborne, do you have anything to add about health equity in regard to actually getting the Pluvicto treatment for African American men?
Well, I think that we've seen the data for decades.
Mm-hmm.
There is a big disparity in terms of outcomes for African American men. But we've also seen the data, and that same data has shown us that when African American men are included, they do almost as well, right? There's some differences, but I wouldn't go as far as to say it's a disparity. It's just a difference, right? And so it's important and this is just one group, right? One group that I focus on. There, as I said, there are many groups, but having inclusion and getting it to everybody is the goal. The goal is that when we see someone, they have your experience, right? Regardless of who they are, they have your experience. And I would say that what you said is very important. Everybody's got to shelve the egos. The egos have got to go, right? Right. Because it all is as important as it is to do this as a physician here at Weill Cornell or with Rad Health Equity. It shouldn't matter where I am, right? I should be able to do this also anywhere. It really shouldn't matter, right? So that's our goal. That's why we're doing this. It should be something that is accessible to all, so we don't really have to think about equity in the same way.
Mr. Faulk, do you have any advice for other patients who may be going through your current journey?
Because it comes right away. It came to me that they should keep a positive mind, think positively, really believe in not only the doctors, but in yourself and your ability to accept what is told to you and what is provided for your treatments, to have a positive mind about the outcome of it, because I think that healing starts from within. That's the foundation, I would say, and the things that happen to help that foundation stay strong and to build on it are things that the other physicians can provide for you as a patient. And I think that once you give that up to those around you that are physicians and that are help orientated, you'll begin on your path towards a good end. And when I say end, I mean a beginning of life as you may have known it before you had this ailment.
Okay, and Dr. Osborne, do you have any advice for patients, providers, or researchers that you'd like to announce here?
Well, I think my advice for providers, I'll sort of reiterate what I had spoken about before. It's important to understand that we're a very important part of the process. And part of that process is acknowledging that we could do better, right? Not that we're not doing well, but that we can do better. Because you don't know what you don't see, right? So just because it seems like within your sphere, everything is perfect. Doesn't mean that there's someone outside of the sphere who can be brought in. And so one has to think about the totality, right, of what's out there and everybody's experience and try and bring them to this point. And the positive attitude is very important, right? Because that is part of the journey. And part of having a positive attitude is knowing that people are treating you in that way.
Yes,
right?
That's very important. And I want to add that please share your experience that you go through with this ailment and your physicians. Share it. Sorry.
Do you have any advice for family members or the spouse of maybe a patient who would be undergoing the Pluvicto treatment or treatment similar to Pluvicto?
It's a hard thing to do is give my opinion on. People are different. Family members just need to be loving like they have been, hopefully, and caring about the patient's mental health as well as their physical health, because you do go through psychological and variances in how you feel and see even yourself. So if your family members can be a little understanding during this time, because you may be irritable, you may not feel like talking, you may be off, you may experience deep thought, depression, various things of that nature, and it's helpful that those around you understand that this is part of the process and perhaps part of the patient's process of healing, to go through this mental gymnastics, so to speak. And just be as supportive as possible, and be like my wife on your appointments, and when should you make them, and who you sit with, and how long will you be there. Book that garage over there for your car so you can be there on time. Excuse me. And some administrative help to your family member who is a patient is also very helpful as well. And to just keep them on point and keep you sane, because you know what's happening with your loved one with regards to their ailment. And to become educated on the treatments and the possible side effects, to watch your loved one and see if things are changing, and to aware the physicians and also the patient as well, and have a conversation about it, not stick it under the rug and like it's not happening. Oh, he's all right. No, it's not like that. So those are the things I would suggest. As I say, each person is different, but that would be helpful if they could take that approach to the ailment.
Thank you. And Dr. Osborne, do you have any closing remarks?
Well, I just want to thank you.
Thank you, Doctor.
It's a pleasure. It took a little while for us to get this
together. We got it.
Perseverance.
Thank you for pursuing it. I appreciate
for
that.
sure.
Yes.
Absolutely.
Thanks to Dr. Osborne, Ms. Dixon, and Mr. Faulk for this discussion, and for introducing the patient experience with this new radiopharmaceutical treatment for metastatic castration-resistant prostate cancer. If you have any questions or need more information, please check out our website at zerocancer.org. Thank you.